have to introduce the next speaker, Renato Muniz Teixeira, and the sagittal toracolumbar profile realignment, consideration through posterior X anterior interbody fusion. What are the limits? Please.
This is the image of the first meetings we have in Rio in 2017, the first BRICS meeting. This is the hospital, the public hospital where we work in Rio. It's the National Institute of Orthopedics and Traumatology. And I would like to show you our experience through these years in our reality. The goals for surgical measurement are to restore the spinal biomechanic, cosmetic by improved by sagittal contour, restore physiological lordosis and sagittal balance, improve self-esteem, pain, comfort, respiratory, visceral impairment, decompress the neurostructures, and stabilize the unstable segments. The aim of surgical management, the goals you all might know is SVA less than 15 millimeter, PT less than 20, and spinal pelvic harmony, lordosis, and PI around 10 degrees of average. We consider in lumbar spine the difference between the segment L4-S1 and the upper segment. The lower segment corresponds to 75% of lumbar lordosis. And that's why we concern different for each segment and treat in different way. Frequent cause of lumbar sagittal. Multi-level lumbar stenosis, previous surgeries, ADS progression, PJK, isolated laminectomy, stress fractures, post-traumatic deformities, osteoporotic deformities, pseudoarthrosis, ankylosis, infections, and tumors. But the most frequently are degenerative and iatrogenic causes in the majority of the cases. The factors in obtaining an ideal spinopelvic alignment depends of factors related to the patient, comorbidities, general conditions, factors related to the surgeon, factors related with the surgical procedure, hospital facilities, and some family and social contexts. Type of surgeries. Being a posterior approach, we got PLIF, TLIF, SPO, eggshell modification, FPO, polysegment, wedge, osteotomy, and in VCR. Restriction correction, symptomatic ASD to obtain a spinopelvic alignment. We still have problems related to the patient, failed back, issues related to medication, factors related to the severity of malalignment, and factors related with bone quality. The PLIF is possible to obtain a lateral alignment using with the correct position of the case and the position of the patient and a careful study of the case. PLIF and TLIF, introduced in 1998, and you can work with a reasonable safety for many patients, and is worldwide more used for realignment in daily patients. The process for PLIF and TLIF permits 360 fusion in one incision, assessed through posterior elements, no anterior column distracts, hinge, anterior middle column, good even in collapse IVD, correction between 5 to 15 degree per level, good neurological decompression. Limited correct coronal imbalance, requires banana type cage, relies on surgery expertise to reach best results, good bone quality, extensive epidural managed, arachnoidite and muscle injuries. Smith-Peterson is also useful in mobile spines, but introduced in 1945. The modifications, just like eggshells, and with anterior approach used with Smith-Peterson permits a better correction with better rates of well-succeed results. Pros: remove posterior elements, can be repeated at several levels. Asymmetrical resection for coronal deformity correction. 5 to 15 degrees of correction per level, if you use alone, of course. It's good for elderly and frail population. Cons: elongates length anterior column. It's not possible. When it happens, it can cause some kind of vascular complications. Difficult closing gaps in the levels, which leads to a high percentage of pseudarthrosis when it's used alone. A frequent need for anterior release and fusion. For example, if you got a mobile spine, you have treated in a different way than a fixed spine. In a mobile spine, you have a compensatory mechanism, so you can have flex hip, and you got a thoracic lordose. And when the patient has a high PA, the high PA is the most important PSO. When we need to do a big correction. Okay. We need different solutions according to deformity. There are some modification of PSO, just like corneal osteotomy that permits a large correction, introduced in 2015. In this paper, we can see that we can get almost good correction with different kind of technique, just like anterior dissection with posterior enclosed wedge. PSO, isolate, or PSO with resection proximal disc and plate. You can get different results, but they are quite similar. PSO is a surgery that's a high risk, high bleeding, high tax of complication in our hands, but we perform it in some case, but not always. The pros for pedicle substructure osteotomy: preserve the length of the anterior column, sagittal correct in one single level, asymmetric resection for coronal deformity correction between 25 to 55% per level. Cons: technically demanding, substantial bleeding, good patient selection, risk neurologic injury, high pseudarthrosis as a standalone traditional way. VCR. is technically demanding and exhausting procedure with possible risk for complication. We avoid to use this procedure in lumbar spine. But it permits a radical correction in a single level in both planes, coronal plus sagittal, shorten the spine, relieves tension neurovascular structures and correction between 50 to 70%. Cons, technically extremely demanding, high perioperative morbidity, thoracolumbar nerve roots, high complication rate in 3 columns osteotomies. And what are the limits? You see, we have a high tax of complication, between 20 to 6% in almost all kinds of osteotomies. And why not think anterior with more frequency? In sagittal deformity, for example, in scoliosis deformity, we should think about flexible and partial flexible or rigid. When we got flexible deformity, we try to perform the lowest risk procedure. Use of anterior is useful to reduce tissue damage, accelerate chance for fusion, accelerate opportunity for alignment. But it needs a careful evaluation of the patient. When the main patient clinics complaint related to mechanical symptoms, axial pain, is better than patients with radicular pain and claudical symptoms. Is useful, especially in previous anterior surgery, posterior surgery. And the best anatomical level to be achieved is L4-S1. It needs anatomical knowledge, patient selection. Of course, a fat patient is different from a thin patient. And we need a good study of the exons. The goals of the treatment, of course, are the same as in posterior approach: nerve compression, pain generators, instability, and alignment. You see, in this case, we got a deformity, a traumatic deformity. We can, if we use for anterior approach in this case, you're gonna have a lower risk for patient, in my opinion. So made anterior approach, a 2-step surgery in one time of anesthetic procedure, and you can have low bleeding and less aggressive than, in my point of view, as PSO osteotomy. The limits of correction of sagittal imbalance, talking about X-lift or lateral lift, is that you correct less than 10 to 10 degrees of correction, and 5 centimeters or SVA. So, and there's a lack of constant reporting on sagittal balance restoration with missed lateral lift, and this is our experience. The positioning of the case is important in lateral lift to get a reasonable restoration. And lateral lift, the pros for lateral lift, that you can reach to 12 to L5, good for correction in mild or moderate coronal and sagittal deformity with lateral stance, and is superior to posterior approach in disc height restoration. But in contrary, neuromonitoring neuromonitoring is essential, not suitable for L5-S1. There's a risk of neurological and vascular injury in distal levels, and there's a high cost. The contraindications also is severe central stenosis, high-grade spondylolisthesis, and recessed stenosis. The ALIF is used to reach L5-4-5-1, but frequently we can do in 3 levels, including 3 and 4. The problem is surgeon has no daily anatomy familiarity with the procedure. The pros, there's a good lordotic restoration. The unique procedure that address L5-S1, as the majority of patients has failed back surgery, they underwent to surgery. In the majority of these procedures, is located between 5-4 and 5 L5-S1. So the ALIF is very useful in daily proceduring. Indirect decompression of neuroforamen is also an advantage of anterior restoration rate and high tax of fusion. We never had, as I remember, pseudoarthrosis in ALIF. The contrary is limit above L4, L5, obesity, almost all required posterior procedures, long learning curve, vascular lesion, ureteral lesion, and retrograde ejaculation, but these are not so high incidence. So, talking about ALIF, we address L5, L4, S1. We're concerned that 75% of lumbar lordosis is between this. Okay, wrong. So, failed back. 2 previous surgery. You see, you can restore 23 degrees in 1 step anterior proceeding. 2 days after surgery, a few years later, is a top in the magazine by a rescue, a female rescue. 57 years old, congenital fixed deformity, present with intractable back pain. Anterior approach, we can get 4 levels and a good mobility in spite of fixation, arthrodesis. That's why people with high PA has a good compensatory, is different from people with low PA. So you can get a good restoration. That's the most, the assess we do. We reach the posterior peritoneum, hepatoperitoneum without no bleeding. If you take care with the vessels and hypogastric plexus using cold blades, there's a low incidence of complication, retrograde ejaculation, for example. In this case, you can see 3 levels of anterior approach. The bleeding is very slow, and we have some in the daily, a lot of revisions like this that comes people with laminectomy, we underwent surgery, so it's very difficult to restore this patient by a posterior approach. So a combined approach is very useful. We try to use 2 cases instead of 1. With the templates, you can spread and restore the lordose better than the other methods that we know. So it's a local brand, I made it there. And we use the last 30 years, the same techniques using templates. And then you can get this result. Any kind of case that you have can use. We just pre-cut in 35 degrees L5, S1. And you got always a good arthrodesis. Is another case, 3 levels. with a good restoration balance. It's anterior-posterior approach. When you use coverage for stability, you can have a good coverage of bone chips if you insert around the cage in the even T-leaf and getting 50 or more, 50% of cover of bone chips, the same as you got in I-leaf, if you can use an extra bone. The limits and conclusion. Limits related to the patient, to the surgeon, and to the hospital. Wrong perception of the type of deformity in both planes. Calculate the ideal spinopelvic alignment for each patient. Each type of osteotomy, posterior interbone fusion has its expected goals. Mechanical correction has no limits, but does it work for the PT? We always look for the PT restoration. And the main goal is an harmonious balance to spine in both planes. We work to PT and SVA. This is the main goal for the sagittal restoration. Weigh the pros and cons of all issues discussed in order to know the limits, when to stop and make the best final decision. Less invasive anterior-posterior techniques for fusion procedure has also lowered the threshold for fusion operations, especially in less health patients. Спасибо.
Thank you very much, Рената. Можем задать пару вопросов, потому что у нас одного китайского товарища пока нету.
Сергей Васильевич, у меня к вам вопросы. Но все мы знаем, что если вкручиваем винт, через какое-то время может быть расшатывание внутри кости. Вот относительно динамических систем, я понимаю, там срок наблюдения довольно уже большой. Были ли случаи, когда вы видите, что, когда вы делаете КТ, вы видите подвижность винта внутри установленного позвонка?
Ни одного, честно говоря, расшатывания не было. Вот 316 пациентов, больше, чем есть трехлетнее наблюдение, ни одного. Потому что динамический корд, он, видимо, так скажем, снижает нагрузку на винт в кости, поэтому этого не видели.
И второй вопрос. Динамическая фиксация, есть ли возрастные ограничения?